Good afternoon, sir. Good afternoon, respected seniors and dear friends. I would like to thank AIOC and sir for this wonderful opportunity to present. The topic of my presentation is aqueous angiography guided minimally invasive glaucoma surgeries. We all know that aqueous flows out of the anterior chamber via either the trabecular meshwork or the uveoscleral pathway. Aqueous angiography allows us to visualize the flow of aqueous via the trabecular meshwork. So how do we perform this procedure? We take 0.1% of endocyanin green dye, which is injected in the anterior chamber, and we visualize the flow of the dye. This denotes the aqueous outflow pathways along the limbus, as you can see in the video. And in this case, we can see a 360-degree good flow that is there in this patient. So how do we capture? The machine used, no financial interest, is a flex module of the Spectralis HRA OCT, and this is how the OT setup is done. The quantitative assessment of the aqueous angiographic image that has been acquired is done by using the ImageJ software, and we have noted increased pixel density on the nasal quadrant, followed by the superior, inferior, and the least in the temporal one. This has been seen in most of the cases. So this is a slide to summarize the variations of aqueous outflow that we have noticed in our patients by using this technique of aqueous angiography. In the first image, we can see a 360-degree high flow region along the limbus. In the second case, we can see a segmental flow of aqueous pattern. And this is the most common pattern that has been noticed in our patients. A high flow region in the nasal quadrant and a low flow region in the temporal quadrant. And in the third image, we can see a poor flow of aqueous along the limbus. Most of the dye is in the anterior chamber itself. So why do we need aqueous angiography? What are the clinical applications of this technique in glaucoma? One, we can map the high flow region and the low flow region, which in turn can guide the choice of surgery between a MIGS versus a conventional one. It can guide the placements of stent or goniectomy incisions during the surgery. And two, it can also help us assess intraoperative functionality of MIGS. I would like to elaborate these points with the help of a few cases. So in this case, we assessed the functionality of iStent inject and performed aqueous angiography after implanting 2 iStents. So we can see in figure A, the yellow asterisks and the red asterisks are anatomically well-placed iStent inject. And we performed aqueous angiography afterwards. And in figure B, noticed a collector channel. You can see this yellow arrow, which was visible through one of the iStent, but an absence of collector channel through the other. Moving on to the other 2 cases, these 2 cases were cases of moderate POAG, one with a good aqueous outflow. We planned for a canal-based MIGS, that is BANG, and the other with a poor aqueous outflow, and we planned for a conventional surgery, that is trabeculectomy. Hence, aqueous angiography aided in the decision-making between MIGS and the conventional surgery. In another case, we performed aqueous angiography and localized the high flow region to be the nasal quadrant, and we performed BANG here. Our repeat aqueous angiography showed increased angiographic signal in this quadrant, suggestive of an increased flow post-BANG. In another case, we identified the temporal quadrant to be the low flow region and performed BANG at this place. And on repeat aqueous angiography, we noted new recruitment of aqueous channels as denoted by the green arrows. These 2 cases brings us to the burning unanswered question, whether we should place MIGS in the high flow region or in the low flow region. To answer this question, we have an ongoing study at our center, and the early results are, we performed aqueous angiography in patients of mild to moderate POAG, and in group 1, we performed BANG in the high flow region, that is the nasal quadrant, and in group 2, we performed BANG in the low flow region, that is the temporal quadrant, and noted the IOP at 6 months of follow-up. So the early results are that we noted a lower IOP being achieved by BANG in the low flow region, that is the temporal quadrant. And at that time, please note the number of anti-glaucoma medications was similar in both the groups. So our hypothesis is that MIGS, especially BANG, should be performed in the low flow region. As one, it will protect the region of the good flow from scarring, and two, improve the outcomes of this surgery. We have noted a late closure of trabecular opening after BANG. Hence, by performing BANG in the temporal quadrant, we keep the area of high flow, that is usually the nasal quadrant, devoid of scarring. We have also noted a recruitment of temporal aqueous channels by performing BANG there, and hence, BANG in the low flow region can allow for new recruitment of channels. I completely agree that it is technically challenging at present to perform BANG here, and we may think of newer procedures like Tinito and this. Another option that I can give you is that we can perform aqueous angiography, localize a low flow region in the nasal quadrant, and then perform BANG. In another case, we performed aqueous angiography in a case of failed nasal BANG just prior to performing trabeculectomy and found loss of aqueous channels which were earlier present pre-BANG. Hence, this encourages us to think that now we can think of performing MIGS, especially the excisional ones, in the temporal quadrant. The limitations of aqueous angiography are that it is invasive, hence a repeat aqueous angiography is difficult. It requires a sterile OT, and the machine for aqueous angiography is definitely expensive at present. I would like to summarize. The new insight of performing a BANG in the temporal quadrant requires further study and validation at other centers. Aqueous angiography has opened new avenues for targeted and individualized MIGS procedure, as it can guide the choice of surgery, that is MIGS versus a conventional one, and can guide the placements of stent or gonioectomy incision in the targeted high flow or low flow region. Aqueous angiography can also assess functionality of MIGS, such as iStent inject, intraoperatively. I would like to acknowledge my mentor and chief surgeon, Professor Tanuj Dada, Dr. Anand Naik Buke, and Dr. Ashi Gupta, and all our patients. Thank you so much.
Thank you, Nitika, for all the hard work and exceptional presentation.